Press the red arrow.
The broadcast is now starting. All attendees are in listen-only mode.
All right, good morning and welcome to Fundamentals of Occlusion. My name is Sarah and I will be facilitating today's webinar. I want to begin by going over a few housekeeping items. First, in the upper right-hand corner of your screen, you should see a questions box. So at any time during the webinar you have any questions, please feel free to type those in. We will be answering any and all questions at the end of the webinar. In addition, the course is NBC approved for one credit hour. So within about 24 hours, you'll receive information on how to obtain your CE credit. And we'll also be posting this webinar on our website. So in case you missed any portion of it or would like another review, you can just log on to whitmix.com and view it again at your own time. Now, without further ado, I'd like to introduce Craig Pickett. For those of you that do not know, Craig is our technical support manager here at Whitmix and has over 25 years experience in the dental laboratory field. So, Craig?
All right, good morning, everybody, and thank you for joining us this morning. As advertised, this is really a course for beginners and aimed at beginners, for those of you who want also to review some of these terms and basic kind of occlusion methods. Now, some of you who have more intricate or complicated questions may want to go ahead and email those questions to us here at Whitmix. You can reach me directly at cpickett@whitmix.com, and we can answer those questions for you. I want to stay kind of on a level that's a little bit more simple and basic today, if possible. Let's go ahead and we'll start right off. Except that my my clicker's not working at the moment. It was and is not currently. So we'll get to it. Here we go. Thank you. It's always good to have good technical help with me. Appreciate it, Sarah. All right. First of all, we need to recognize and realize that dentistry has a common language. And if you cannot speak or write this common language, then you cannot communicate in our industry. And so, although we have pet names for things and various kinds of ways that we talk about stuff, we need to understand and use that common language. And so because of that, we're going to go over some of those common terms for today. Now, depending upon where your dentist or you as a technician went to school, there are going to be different names and terms for different structures of the mouth. And you need to be fluent in all of those terms that relate to your individual dentist. So please make sure that you're capturing that information and are able to communicate back to him with the same language that he learned or she learned in school. Now, we're going to start right off with reference planes. Planes are a flat section which are defined by at least 3 points in space. The body and teeth are all divided into various planes. And you can see in this particular illustration, we have a frontal plane, we have a horizontal plane, and then we also have a sagittal plane. And the sagittal plane can occur on either side of that frontal or median plane. Now, here we are translating directly into the head and neck, and you'll notice we have what is called the frontal plane once again, and also referenced is what's called the mid-sagittal plane, which would be the same as the medial or the median plane. Now, we're often talking, too, about the plane of occlusion, and that plane, of course, is described as that relationship between the upper and lower teeth as they come together in a natural bite. We also use, commonly, the curve of Spee. This is that angle or that curve which extends from the anterior of the teeth to the posterior of the teeth. In crown and bridge, we're generally just following whatever angles happen to be there relative to the remaining dentition, which is there. These curves are used a lot more by those that are practicing removable restoration dentistry and are terribly important to them. In Crown and Bridge, we fly a little loose with curve of speed. The other one is curve of Wilson, which is a curve that extends from one side of the mouth to the other and generally follows that inclination that the teeth have to fall what we will call lingually, or towards the tongue. Now, there's also something called the sphere of Monson. This is described by the combination of the curve of Wilson and the curve of speed, and it's a shape that's roughly the size of a tennis ball that occurs at the base. This is not the best illustration, but I think you can see it. Now, we also have what is called the Bonwell, which is a triangle, an equilateral triangle. This is based on 10 centimeters or 110 millimeters of space, which occurs between the condyles of the mandible and the central point of the lower incisors. And a lot of what we will base the theory of occlusion around articulation is based on Bonwell. All right, now we also use the Frankfurt horizontal plane. This is established, as you can see in large words, by the transverse horizontal axis of the mandible with a point on the inferior border of the right or left orbit, or what is called the orbitale. The orbit is that piece at the bottom of the eye there, and it runs through the central part of your ear. And this is that plane that most face bows use as a beginning point of measurement. And we'll look at that in just a second. There's a typical registration. This is using the Whitmix face bow. You can see the Frankfurt plane there is the actual bow, the legs of the bow there that are placed into the patient's ear and are positioned, in the case of the Whitmix unit, by the nasion. And then the bite fork, which is held in the patient's mouth, registers the occlusal table in relationship to that Frankfurt plane. And then this information is held by the face bow registration and transferred to a large frame articulate. Now, we're using some initials now that weren't used many years ago. MI is the first one. This is maximal intercuspation. This occurs when the jaws are closed and the teeth are all positioned correctly in what we used to call cusp-fossa relationship. That's our standard closer point that we're looking for in Crown and Bridge a lot, because that's the relationship left with the teeth that we're working with. In removable, it's something that you're finding and creating. Now, there are two reference points that are sometimes confusing to many technicians that are talked about now. The first one is centric occlusion. This refers to that relationship of the mandible to the maxilla when the teeth are in MI. So when you're in a closed position, teeth are all together in the natural spot that they fall. This is CO. Now, if you look at the illustration at the top, where the condylar disc assembly would be, you'll notice that it may or may not be forward or backwards in the fossa. And this is going to be dependent upon, of course, the individual patient, where exactly that falls. But we're relying on centric occlusion, or CO, based on position of the teeth. The next one is CR, and this relationship, or centric relation, is where the mandible is in the most superior or the highest position against the eminentia. So it's back and up, if you would. And you'll notice that in the top of the illustration there, it's seated properly. The other thing you'll notice that this is irrespective of the position of the teeth. They may or may not be occluded correctly, and more than likely they're not. And the variance of that is going to be based on the individual patient. All right, now let's talk about some structure. All technicians ought to know the general structures or parts of the tooth. the crown, the neck area, the root area. You should know what is the enamel, what is the dentin, what is the pulp chamber, and the pulp. You should know where the apical foramen is. You should know that there is an alveolar process, which is the bone that surrounds the roots of the teeth. You should know also that they're held in place by the periodontal ligament, not by the bone, and that there is a blood and nerve supply that runs through that apical foramen and into the rest of the pulp that keeps the teeth alive. Now, you should know the relationship between what is referred to as the clinical crown, or that portion of the tooth that is above the gingiva or the gums of the teeth, versus the neck area, which is closest to the gingiva, and then the root. If we don't design that properly, then we begin to have problems in that area, and we have what is or can be turned into periodontal problems or problems with periodontal ligaments. So it's important that you understand that relationship and how those structures meet and function together. Now, the maxilla is that part of the skull that supports the upper teeth. It is not a mobile part of the head. We often, in using an articulator, are moving the upper member of the articulator around, and we lose track of the fact that that piece in the human body actually stays fairly rigid. Then there's the mandible, which is also known as the jaw, and this is, of course, the lower member of the oral cavity. This is the piece that moves when we're actually chewing and supports the lower teeth. There are various pieces of that mandible that you can, of course, study later. The piece that becomes important to you as you look at function of the jaw is really the condylar process and how that process fits into the fossa area. All right, now we have the palate, which is composed of two parts, the soft and the hard. This is the upper portion of your oral cavity. The crown and bridge technicians don't refer very often to some of the landmarks there, but the removable guys do. There's the incisive papilla, which will mark your center position if you do not have teeth remaining. And there's my favorite, which is the palatine rugae, or rugae, depending upon where you were schooled and how you pronounce it. It's terribly important for speech and can be problematic if it's not reproduced in movable restoration. So a lot of the removable guys out there will use wax patterns that are already produced, or perhaps have even somehow done an impression, created their own, and have a block of plaster designed now to impress the rugae into soft wax. Then we have the TMJ. Now the TMJ, or the temporomandibular joint, is a study in and of itself. We're not going to spend a lot of time on that today. What you need to know basically is that that's where the maxilla and the mandible tie together. This is the site where the condyles rotate and translate inside the fossa. It has a lot of different parts that are all involved, and as those parts wear or deteriorate and come into all kinds of related problems. We call these, or refer to them, as TMJ disorders, and they can include headache, migraine, abnormal tooth wear, masturbatory discomfort, speech irregularities, and in many cases, continuous pain that can't be quite diagnosed. If you look at this slide, you can see normal positioning and normal movement in the top two left and central slide pictures there. And then you can see what happens when you have an abnormal movement of that joint and the impinging effect that it has on the disc during muscle displacement. There's a lot that goes on with that. It's a specialty field. And if you encounter or are told that you have a patient with TMJ disorder, then as you're doing your reproductive work with those teeth, you're going to need to make sure that you're in good, close communication with the restoring dentist so that you can help to overcome as much of that issue as possible. Now, let's do some direction. These are kind of classic and basic. Anterior is towards the front of the face or the front of the mouth. Every tooth has an anterior surface. The next one, of course, is the posterior, which means towards the back of the mouth. This is the position of anything that is towards the back of the mouth or the head can be referred to as posterior. And usually when we say the posterior teeth, we're talking about that group of teeth that includes the bicuspids or premolars and the molars. Now, we also have mesial, which means the surface that is most close toward the mesial or the median line, that central line of structure. You can see it in the example that's up there on the screen. Each and every tooth as you go has a mesial surface. Next one is distal. That's probably the easiest one to remember because it's the most distant from that median line. Then you have the occlusal surface. This surface is the surface that comes into occlusion or contact with the opposing dentition. It's also referred to as the chewing surface or the top surface of the teeth. Then you also have the lingual surface, which is the surface closest to the tongue on your teeth. Now that surface can also be referred to in upper teeth as the palatal surface because it's the surface most close to the palate. This will depend upon where your doctors or where you went to school, but don't be surprised if those terms are used interchangeably. Then we have the buccal surface. This is the side of the tooth closest to the buccinator muscle, which is the outside surface of posterior teeth. The next one is the facial or the labial surface, and that's the surface which comes in contact with the face or the front portion of your face or the labia or the lips. And both of those terms can be used interchangeably. The next one that's used a lot is lateral, and that simply means to the side of. Any surface could be lateral, just depending upon where you're looking from. Now, the other thing that's important to know and understand is the long axis of the tooth. Every tooth has a long axis. With the crown and bridge folks, we're seeing a prepped tooth. And to envision placement then of the clinical crown that you're going to create, you need to also understand where the long axis of that tooth is running so that you can position that crown properly. Or its later loading that will take place. For the removable guys, long axis, you've got a denture tooth there that you're placing, and that rotation is going to be important too to understand where you're placing those denture teeth. So long axis. Then we have anterior landmarks. These are found on any of the anterior teeth, both the upper and the lower. And one that sticks out is that anterior teeth also have marginal ridges. A lot of times we don't talk about that. But you'll see that there are several landmarks, including the incisal edge that we're familiar with, the cingulum, which is now number 7 on your screen there. And also the junction, the cemental enamel junction. And of course, there is a lingual fossa that's involved there. Most technicians forget that those anterior teeth have a fossa. Then we have posterior occlusal landmarks, unless there's significantly more. I won't go through every one of them, but you'll notice the basics up there are the cusps, the grooves, and the ridges, and the fossa, or the what can also be known as the pit, which is at the bottom of it. Now we have different types of identifying systems for each each tooth. The first one that we're going to talk about here is the numerical system. In my mind, this is the easiest one to communicate because each tooth has its own number. We begin at the patient's upper right third molar. So if you'll take your hand and finger, just point to your upper right third molar, which would be where your wisdom tooth is or was. That continues to hold that numerical space, whether it's been extracted or not. That's your number 1, and then you count around each tooth till you get to 16 on your upper left-hand side, drop straight down. That would be 17 on the lower left-hand side, and then come all the way around to number 32. You always reference each tooth once again, whether it's been extracted or not. It's still that position. This is simple, I think. If I am talking with you over the telephone and just say we're referring to tooth number 9, you know that that is the upper left central. It's just easy. Now the next one is the Palmer or the military system, and you'll notice that the teeth have been broken into quadrants, and each quadrant is numbered 1 through 8. You'll see under the example on the left side of your screen there how to write each of these. There's a bracket and then going in the correct direction. With the example, this would be the patient's upper left, number 1, which would be the number 9 tooth in the other system. The thing that can be a little bit discouraging about this particular system, especially here, is that if it's not written properly, it can look like L1, and that can be confusing at times. You can confuse that with lower 1. And so we have to watch that and know that your particular doctor is using this system. Now the third system that's out there is the international system. This, once again, is broken into quadrants, being numbered 1 through 8. The teeth are numbered 1 through 8, and each quadrant is also given a number. And so if we use that same example of the number 9 tooth, which is patient's upper left central incisor, that would be 2-1. Or in the examples that I used here, the upper right third molar is 1-8, and the lower left third molar is 3-8. Sometimes the confusion there, for example, if you use the upper right third molar and you miss the dash, you get tooth number 18, which is a completely different tooth, of course. So the onus is on the technician to understand the communication system that the dentist is using. Now, when it comes to the names of the teeth, some teeth have dual names. Canines are often called cuspids. Premolars are called bicuspids. Third molar is often called a wisdom tooth, and we go through it as we go. They'll often be referred to interchangeably, and so you need to be familiar with each of those names of the teeth. Now, in primary teeth or baby teeth, it's a little bit different. The identifiers are not numbers, but they are letters. They start with, once again, the patient's upper right molar as A, and then runs around B, C, D, F, E, F, G, H, I, etc. The names, however, are the same. You're still going to call it a central incisor, a lateral incisor, a canine, or a cuspid, a first molar, second molar. Now let's talk about the muscles of mastication. Those of you who went through school went through this and probably groaned as you did, but it's important to know basically which muscles are doing what and how they function. And then if you want to get into all the names of the muscles, you certainly can. They're broken into groups, and the first group we're going to talk about are the elevator muscles. These are the muscles that lift the mandible up against the maxilla and create the chewing motion. Okay, they are the masseter, the medial pterygoid, and the temporalis, and here they are. There are also positioner muscles. These help to position that mandible in the correct spot for what it is that you're going to do. Those are the lateral pterygoid and the temporalis. Then we have muscles of speech and swallowing. They include the buccinator, the orbicularis, the tongue, and the depressor muscles as a group. Now, the masseter, before we go there, we should tell you that all muscles have an origin, an insertion, and a function. The origin is where that muscle begins. The insertion is where it ends or connects to. And if you look at this example of the masseter, you'll see the origin up on the I just lost it for a moment. Sorry, on the maxilla, and the insertion down on the, on the mandible, and the insertion on the lateral surface of the ramus coronoid process, which is up on the mandible. There we go. Let's review that again, just so I didn't confuse you. The origin up on the zygomatic arch, which is on the maxilla, the insertion on the mandible. Now, what's its function? It elevates the mandible and clenches the teeth. So you can feel that if you'll put your hand, left or right, up on the side of your face near that lower portion of your jaw where it angles up, and then go ahead and clench your teeth, and you can feel that muscle function. Now, the medial pterygoid. This also helps to elevate, okay? And there it is. You can see its position. The temporalis is that large banded muscle that actually is where where you feel migraine headaches. Those of you who get that, you know where that kind of feeling is up there on the side of your head. If you put your palm up on the side of your head and then close your jaw and clench, you can feel that muscle working. The next one is the lateral pterygoid. That's kind of a tough muscle to feel working. You have to dig around a bit to find that one. But as you move your jaw back and forth a bit, if you really reach in there, just about where your ear is, just in front of your ear, you can feel that little muscle working around. Okay? It holds the disc, your disc over the condyle, and pulls the mandible down and forward, okay? Which is important as you move into your protrusive position of the mandible. Okay, then we have the buccinator muscle. Remember back we have the buccal surface of the teeth. This function compresses your teeth and it aids in mastication or chewing. And its function really is to push the food that falls off the occlusal table back onto the occlusal table. The next one is the orbicularis. That was my favorite to remember. Just kind of has an interesting sounding name, the orbicularis. Its function is lips and facial expression. Now, it used to be thought of as a sphincter muscle, a single muscle in a circle that closed and opened, but now it's really been defined as 4 separate muscles that function together. And if you think of that, you'll know then why Elvis was capable of making that kind of left lip lift that he did, is because he could pull up that one side of the orbicularis. All right, then we have the tongue, which is also a muscle. And of course, it helps us in speech and swallowing and chewing because it pushes the food from the interior surface back onto the table of the occlusal table for Okay. And then we have a whole group of muscles called the depressor muscles that help to pull the mandible. This is the mylohyoid, the digastric, and the stylohyoid, okay, all the way to the base of the tongue. Those of you who get allergies and the back of or the upper bit of your palate, the backside of your throat itches a lot, you use that muscle to get your tongue up there and try and scratch it. All right, now let's talk a little bit about occlusion and function. And once again, as I said, this is a very high-level conversation. It's not in depth. If you want to get more into depth about that, we've got some great folks here at Whitman that are all capable of talking to you about occlusion and function. Simply said, occlusion is defined as making contact with the surface of an opposing tooth when the jaws are closed. We talk about that in terms, as technicians, in terms of how the teeth are going to fit together and close on each other. We know it's a lot more than that because it has to do with movement. And it has to do with individual movement of individual patients. And that movement is defined by everything that we've been talking about their tooth surface, about the shape of the condyle, about their muscles and how they operate, whether or not they have TMJ disorder, all those kinds of things combined. We generally will break occlusion into three different classes. First one is class 1 occlusion. These are teeth that are aligned in cusp-fossa relationship with their antagonist tooth, or the tooth opposite them. We often call this normal occlusion, although all of both the other classes are pretty normal too. But this is the standard of occlusion that we try to get. The second, or class 2 occlusion, is when we have the anterior maxillary teeth protruded or pushing forward horizontally over the mandibular. You'll notice too that the position of the buccal cusp tips have also moved forward, but it should be class 1. And we also call this overjet. Overbite is another term that's often used. That's the depth that you bite over, that your anterior, upper anterior incisors bite over the lower incisors. Overjet is how far forward we come. Then we have what's called class 3 occlusion. This is where the anterior maxillary dentition are behind or posterior to the mandibular anterior teeth. Posterior teeth are usually in crossbite, which means that they've also moved position, the upper teeth, into the inside of the occlusal table rather than outside those cusps. Okay? Or the teeth rest inside the fossa of the lower dentition. This can cause some real interesting sort of bite relationships and restorative problems with function as you create teeth that need to move in that relationship rather than the standard or class 1 relationship. So you need to be very careful as you produce those cusps. Things which look very nice may actually be interfering in the function of a bite line. All right, now function is a broad term also. It is defined, as we see here, as a factor related to or dependent upon other factors, which is a pretty vague definition. You will notice on the right-hand side of the screen that we've listed basically the teeth as a group: incisors, canines, premolars, molars, and third molars. And then we've given you a definition of what that function is. The incisors are those 8 teeth in the front and center of your mouth. These are the ones you use to take bites out of your food. They're the cutting teeth, if you would, at times. They generally develop around 6 months for that first or primary set, and between 6 and 8 years for your adult set of teeth. That's our favorite photographs we ever had of ourselves, where our two front anterior teeth look like they're about 3 times the size of our face. Everybody's got one of those. Generally, nobody pulls that picture out to show anyone. It's kind of that funny stage in little kids' life. The next one are, of course, the canines. These are ripping or tearing teeth. They are what associates us with some of the other predatory animals that are out there, if you would, that all have these sort of meat eater type of teeth in their mouth. These teeth are, when they come in as permanent, also serve as a movement regulator. They allow for the occlusal table to be disengaged and can be worn quite regularly and can be worn off flat. We need to be on the lookout for that kind of restoration also. Premolars can also be referred to as bicuspid, having 2 cusps. They're used for chewing and grinding food. You have 4 of them on the side of your mouth, upper and lower, and develop around age 10 is your permanent. Molars are your primary method for chewing or grinding your food. And then the third molar, which is commonly known as wisdom tooth, are often removed. They're said to be basically not important. Sometimes they get in the way. Sometimes they will erupt in an impacted state where they don't have a clear channel to come up, and therefore be removed so that they don't affect the rest of the dentition mouth. They will have a tendency at times, if they're coming in crooked, to push the other teeth in your mouth forward and misalign them, and that could be problematic also. Now, there are functional movements of the jaw. We refer to these as protrusive. That's where your jaw comes forward. Retrusive, where it moves backwards. Left lateral movement, which is moving to the left. Right lateral movement to the right. Side shift, which is an immediate sort of a movement. Immediate side shift. And then there is rotation, which is a turning movement that the ramus makes in the condyle, and translation, which is another movement as it moves forward and down the condyle, the upper portion of the condyle. So you've got a lot of functional movements that go on with that jaw, not just open and closed. And that brings us to articulation, which is a rather large topic, and we're really going to talk just about a couple of 3 things, and that's the 3 basic types of articulators that are out there. And we're also going to talk for a moment here about what's referred to as arc of closure, which is an interesting thing because it affects all of us, especially in crown and bridge, where there are so many varieties of articulators that are being used currently. Now, an articulator is a mechanical device that simulates the mandibular movement, and that can be a device that simulates it fairly accurately, and also one that doesn't really simulate it, that acts purely as a hinge movement. Now, your larger articulators, like the Whitmix that's shown in the bottom right-hand corner, helps you to mimic the actual movement of the condyle in their fossa, and as does any of the other larger articulators. We here at Whitmix now are producing both the Whitmix articulator, the Danar series of articulators, and also the Hanau series of articulators for your use. Now, a semi-adjustable articulator provides a platform for the use of as much diagnostic information as there is possible really out there now. There are fully adjustable articulators on the market, like the Danar D5A. They're not in use a lot because of the complexity. And so you will see most of the larger articulators that are on the market are semi-adjustable, meaning that they cannot be adjusted for every movement that goes on and each and every size of the patient's head. This is an example of a Hanau articulator. You can see here where the Frankfurt plane, you'll remember that was the horizontal plane extending from basically from the ear to the orbitale, which is the bottom, the bony ridge there at the bottom of your eye socket. And the occlusal plane, which is that piece defined by where the teeth intersect. And remember that this is the information that we would capture using a FACEBO registration. That FACEBO registration would be then transferred to the articulator, and that would also give you your correct relationship back to the fossa, which is indicated there on that articulator. Okay. When you mount a case like this, you get the maximum amount or the majority of the corrected information that you need from the dentist. Now, most of us are not working with a majority of dentists using FACEBO registration. And so we deal with registrations that may simply be a quick bite registration and don't give us the information relative to the condyles in the patient. That requires us then to do what's called arbitrary mounting. Now we're going to do a webinar later here in the year on arbitrary mounting and how to deal with that. There are some tricks to that will give you a little better mounting relationship with the articulator and therefore a little more like the original patient. Hang on one second, we'll get to moving there we go. Here you can see the side view of a patient and a Danar articulator that has a case mounted on it, placed in the relative position of how it would mimic that patient. So notice the condyles are approximately the same place where the head of the rings there would be for the mandible and where it attaches into the maxilla. You'll notice that the teeth, the models are coming together in the occlusal plane right where they should be. This is because this full-size articulator allows for the correct positioning of all of those relationships. Now, this yellow circle is going to give you that occlusal relationship, okay, from the condyle. It's the not Frankfurt plane, but I just lost its name. But the triangle, we'll get to it. Sorry, everyone. That creates that. That's about 110 degree, or it's about 110 millimeter measurement from that point to the lower incisors, and gives us correct positioning in general. Okay, with the exception, of course, that every patient's just a little bit different, but just on average, that's where we are. Okay. Now, if we're using a Foster type articulator, which has been very popular over many years, this would be the position that would be in if we kept the occlusal plane in the same correct position. And you will notice with the placement of this articulate that we have a change in the relative position of where that hinge access is, or where we would normally put the condyle. The distance we're trying to mimic in Bonwell, which is the triangle I was trying to think of a moment ago, sorry about that, is approximately the same, but you'll notice that there's a position change if you look at the green circle relative to what's going on with the yellow circle, which would be the standard. Now, what we're getting to here is what's called the arc of closure. And we'll talk about that as we reference all three types of articulate. Now, probably the most common articulator that's in use in the crown and bridge side of the world is a disposable articulator. There are several different kinds out there. This is probably a very popular one. And you'll notice what happens with the position of the condyle. Now, the occlusal plane is in the same space. However, as we measure the position of the condyle, you'll notice that it has moved dramatically from where the patient's actual condyle is and where the position would be if you were using a semi-adjustable or large-scale, full-scale articulator. You'll also notice with that orange circle that that arc has changed dramatically from the arc which is there with the yellow circle. Now, the correct or incorrect application of articulators can lead to clinical success or failure, depending upon what you're producing. Now, as I said earlier on, crown and bridge, we're using a lot of the existing dentition that is there to give us the landmarks of movement and function. As we move into edentulous cases, you have problems there. Or edentulous, you have problems when you have no teeth left to reference, and you move into an articulator that is not a large-scale articulator, which is, gives you a change in the movement. There's all three of them laid on top of each other, and if you were to, in your mind, imagine a central lined up along the long axis with each of those yellow, green, and orange lines, you'll notice that the tilt or the angulation of that central changes. The movement of the central then would change also. Much more shallow angle, much different angle of attack as you come through. And what we're noticing and finding is that this is creating problems, especially in the posterior region, with early contact or what is often called high occlusion. And so, to combat that, we simply take the cuss tips out of occlusion. Sometimes as many as 2 or 3 tapes short, and just so that there's no interference when the doctor gives the case back. Now, this isn't ideal. I think we all know as technicians it's not ideal, but in part we've created our own problem by working on disposable articulators, which are convenient, but not the best application of the information. What we want to do is to make sure that we keep our dentition functioning. It's a little tougher to recreate without the proper dentition. And without the proper function, it leads us into TMJ issues and other kinds of problematic responses from patients. Now, once again, this was a very high overview of many of these terms of occlusion and function. And we would, here at Whitmix, encourage you to be involved with studying function and looking at how dentition actually works together how the muscles promote that function, what they do, and how each and every case differs, therefore allowing you to produce the best restorative product you can possibly produce for that patient. We encourage you to ask questions. We encourage you to study. If you have any questions, we would love to hear from you. We'll reference you on to different reference material for reading and study. And please, please don't hesitate to give us a call.
All right, so I just want to remind everybody, if you have any questions, please go ahead and type them in the questions box on the right-hand corner of your screen. Also, we had a lot of latecomers today, so if you did miss a portion of today's webinar, it will be up on our website by tomorrow, so feel free to watch it there in your own time. So if anybody has any questions, please go ahead and type them. We'll kind of stick on here for a little bit. But we do have some upcoming webinars. Coming up in August, we have Lean in the Model Room. We also have Getting the Most from Your Articulator. And in September, we have Arbitrary Mounting, which Craig had mentioned earlier. And then in October, we have our Whitnick's Lean Symposium of Dental Technology. And you can actually log on to whitnicks.com for more information on that. There's still no questions coming in, so we're going to go ahead and end today's webinar. If you have or need CDT credit, we will be sending out information on how to obtain that credit. You should get that within 24 to 48 hours of today's webinar. And if you have any questions in addition to that, please email us at cpickett@whitnicks.com or webinar@whitnicks.com as well. So thank you all for your attention today, and